I present this lecture in place of Professor Tadahiro Takada, True Chief of Tokyo Guideline Project. This is the agenda of my talk. I will talk about Tokyo Guideline 207, process of revising Tokyo Guidelines, multi-center study, revised Tokyo Guideline TG13, cholangitis and cholecystitis bundles, and mobile applications for TG13. Tokyo Guideline is the first clinical international guidelines focusing on management of acute cholangitis and cholecystitis. Since there was no diagnosis or severity assessment criteria of acute cholangitis and cholecystitis, main objects of the guidelines are firstly to standardize diagnosis criteria and severe assessment criteria, and secondly to propose best strategies for management of acute cholangitis and cholecystitis. 30 international and more than 50 domestic experts attended at Tokyo International Consensus meeting in April 2007. TG07 were published in JHPB Surgery in 2007. After TG was published, TG was quoted frequently to other papers, and number of citations has been increasing. TG was quoted to New England Journal of Medicine and IDSA and Surgical Infection Society guidelines, and TG was also quoted to textbook of current surgical therapy. But making clinical practice guideline is not final. It should be distributed and assessed and revised. In the revision of Tokyo Guidelines, we performed multi-center study to change diagnostic criteria and severity assessment. Therefore, we prepared to revise Tokyo Guidelines. We started with literature review and evaluated the guidelines with multi-center study. Working group meetings were held more than 20 times. International meetings with Professor Strasberg and Professor Solomkin were also held. Characteristics of TG13 were below. We revised diagnostic criteria of acute cholangitis and cholecystitis based on multi-center analysis. We introduced management bundle and application and adopted many figures and videos. Charcot's triad has a low sensitivity, but its specificity is excellent. Sensitivity and specificity of TG07 were both about 80%, and more than 15% of acute cholecystitis cases were positive in TG07 acute cholangitis criteria. Why sensitivity of Tokyo Guidelines was low? For suspected or definite diagnosis, 2 or more items in A were essential. Therefore, when patient doesn't have 2 or more items in A, definite nor suspected diagnosis is not made, independently of item B or C. Therefore, we performed multi-center study to revise the diagnostic criteria of acute cholangitis. Clinical data of acute cholangitis and other biliary disease were collected retrospectively. There were 798 acute cholangitis and 638 other diseases. Etiology of acute cholangitis were choledochlysis or malignant tumors. Positive of Charcot triad were 18.5% in acute cholangitis and 4.1% in other diseases. Abdominal pain were recognized about half cases of each group. This is diagnostic criteria of acute cholangitis of TG07, but A1, A4, C7, and A2, B5, and A3, B6 means same clinical symptoms or signs retrospectively. Therefore, this grouping, Therefore, these groupings are imbalanced and inappropriate. For the first step, we rearranged A2, B5, A3, B6, and A1, A4, C7. A category means, A category means inflammation, B category indicate cholecystitis, and C category is composed of biliary manifestations. But C1 abdominal pain and C2 history, I'm sorry. And C1 abdominal pain and C2 history of biliary this one. C1 abdominal pain and C2 history of biliary drainage are not specific for acute cholangitis. Finally, this is revised TG13 diagnosis criteria of acute cholangitis. Suspected diagnosis is one item in A plus one item in either B or C, and definite diagnosis is made if at least one item in each category are positive. With this diagnosis criteria, TG13 showed much better sensitivity and false positive rate of acute cholecystitis with same specificity as TG07 in multi-center study. And this is severity assessment criteria for acute cholangitis TG07. Since grade 2 or 1 will reveal after initial treatment, we cannot define at initial phase. Problem of this severity criteria is at initial diagnosis time, we cannot determine whether grade 1 or grade 2 cases. So there are 2 points of revision of severity criteria. One is to determine grade 2 at a diagnosis time, and another is not to be behind with early diagnosis in grade 2 moderate. The predictor of poor prognosis factor and urgent drainage has been reported, but there is not enough drainage predictor in grade 2 moderate. There are poor prognostic factors in acute cholangitis, but some of these are already included in grade 3 severe criteria. This is severity assessment criteria for acute cholangitis in TG13. Grade 3 is the same as that of TG07, except dobutamine that was changed to norepinephrine. Grade 2 moderate acute cholangitis are defined as that with any two of the following conditions: abdominal white blood cell count, high fever, age, hyperbilirubinemia, and hypoalbuminemia. This is concept of treatment acute cholangitis according to severity. In grade 1, mild cases, antibiotics. In grade 2, moderate, biliary drainage. In grade 3, severe, organ support is necessary. Management of acute cholangitis depends on severity. In grade 1 mild cases, antibiotics and general supportive care. In grade 2 moderate, early biliary drainage. In grade 3 cases, urgent biliary drainage and organ support is necessary. Let's move to acute cholecystitis. Controversial point of diagnosis criteria of acute cholecystitis of TG07 were below. Criteria for definite diagnosis 2 were confirmed when acute cholecystitis is suspected clinically, but this is ambiguous, and definite diagnosis could be determined without imaging findings. These are diagnosis criteria of acute cholecystitis of TG13. Cholecystitis suspected when one item in A plus one item in B. A definite diagnosis is made when suspected diagnosis plus imaging findings. With multicenter study case, specificity of TG13 showed much improved. Severity assessment criteria for of acute cholecystitis of TG13 were the only minor changes. In antibiotics section in TG13, we added healthcare-associated infection prophylactic agent for ERCP. Presumptive therapy based on the degree of severity. Some agents are no longer recommended due to resistance. In antibiotics agent, we separate community-acquired or healthcare-associated infection because of the high risk of resistance in the latter. Selection of agent for community-acquired infection is also recommended on the basis of severity grade 1 to 3. This is flowchart for management of acute cholecystitis TG13. Grade 2 with antibiotics and supportive care, you can choose emergency surgery, GB drainage, early or delayed elective laparoscopic cholecystectomy. Murata evaluated more than 60,000 patients with acute cholangitis, and he reported significantly lower risk of the patient with high compliance of Tokyo guidelines. To make high compliance of TG13, we propose management bundle of acute cholangitis and cholecystitis. This is a part of bundles. The bundles include diagnosis assessment, abdominal X-ray, and ultrasound, severity assessment at diagnosis, and within every 24 hours after diagnosis and initial treatment. We also made checklist of TG13 bundles for convenience of clinical use. We also adapted many figures. This is diffuse homogeneous enhancement of the liver in acute cholangitis. We also added many videos as an electric supplement that you can see on journal homepage free. We also made TG13 mobile application. It includes digest of TG13 of acute cholangitis and cholecystitis. Each contains diagnosis or severity criteria, flowchart, bundles. This application can include antimicrobial therapy, and you can also check full text of TG13. With calculator, diagnosis or assessment of severity is done very easily. TG13's apply can be downloaded free. Okay, so please search TG13. After TG13, now we are planning a multi-center retrospective observational study to update causative organisms and prevalence of resistance among patients with acute cholangitis and such adequate timing of cholecystectomy in acute cholecystitis. So this is summary of my talk. TG13 is revised from TG07 with multi-center study. TG13 presented the world's first management bundle of acute cholangitis and mobile applications. TG13 and apply can be downloaded free. As other guidelines, TG13 needs evaluation, especially in other institutions. Now we are planning an international study. These evaluations lead revision and improve Tokyo guideline. And thank you for attention.